Hello, dengar tak suara? Hello?
Assalamualaikum.
Waalaikumsalam, Doktor.
Semua dah ada ke?
Semua ada, Doktor.
Oh, semua ada dah. Okay. So let's start dengan Al-Fatihah. Okay, let's start.
Assalamualaikum warahmatullahi wabarakatuh. Doktor, can we start?
Yes.
Sorry, Doktor. I cannot hear you.
Yes, tak dengar ke? Dengar tak?
Dengar. Boleh start.
Ya kan?
Ni. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hassan, can you present the slide?
Okay, hold on, ya.
Hassan, okay kan?
Hold on, ya. Give me a moment.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. You all can hear my voice, right?
Yes.
Yes.
Okay. Okay. So we open our seminar today with kita Al-Fatihah. Okay, I will start my presentation. My name is Muhammad Afzuddin bin Abdul Razak. So my presentation will be regarding electrocardiogram ECG. So next. So as an introduction, ECG is a test in which we assess the electrical activity of the heart, and it provides several valuable bedside information such as heart rate, the rhythm, the size of chamber, and also wall thickness of the chamber. And also ECG will help us in the diagnosis of the any arrhythmia, any presence of structural abnormalities of the heart, and also detect the congenital heart disease. Okay, next. Okay, so there are several indications for doing the ECG. First, if there any presence of the symptoms, exertional symptoms, cyanotic episode, any sign of heart failure in the children, if we suspect hypothermia, electrolyte imbalance, and any presence of arrhythmia or palpitation in the children. And also, if there is a presence of several disease regarding the cardiac itself, such as Kawasaki disease, rheumatic fever, myocarditis, and so on. Okay. Next. Okay. So regarding the complication of the ECG, in which it's only the allergic reaction that can occur at the skin of the children. So this is the only complication that we are afraid for. All right. Next. Okay. So for the list of equipment that will be used, basically we all know all of this. We need to have a ECG machine with the ECG electrodes and ECG paper, and we also use electrode gel and also ECG accessories. ECG accessories lah. If the ECG if the can be moved lah from one place to another place. Okay, so basically we all know this. Right. Okay, next. Okay, so about the how do we perform the ECG on the children. Basically, as we all know, we verify the patient via the parents, and then we position the child comfortably on the bed. Remove the clothing from the waist up that may interfere with the procedure, and then we attach the electrode on the child's chest, arm, and the legs. So regarding the attachment of or the placement of the electrodes, I will explain in the next slide. And start the ECG, and once complete tracing, disconnect the leads and remove the electrodes. Okay. So regarding the ECG placement, so for the limbs, so we will place on top part of the arms and legs or more proximal position. This is to make sure less muscle interference. The suggestion is we place on the bony prominence. Next is precordial placement. So as you can see in the table, basically more or less just same like an adult. So for V1 and V2, we place on the fourth intercostal space, V1 on the right sternal border and the V2 on the left sternal. And then we first place the V4 at the fifth intercostal space at the left mid clavicular line, and then we place the V3 the midway between the V2 and also V4. And next we place the V6 first at the maxillary line, same horizontal line as V4, and then we place the V5 between that V4 and V6. Okay. And then to add on, we put on V4R at the fifth intercostal space at the right mid clavicular line. Okay. Okay, this I provide a video to show how the electrode will be placed on the children. Can you play the video, Hassan? Sepatutnya ada suara. Macam mana? Hassan kena
Stop and then share again, but tick the box below that. Share with audio. So stop sharing and then share again by ticking the box.
Hello, my name's Tom, lecturer in adult nursing here at Staffordshire University. Just going to be going through this afternoon the placement of electrocardiogram or ECG electrodes in a child. Principles are similar to an adult, but thought it might be useful to just demonstrate on young Boris here. Reasons why you might want to perform this is because of they may have an abnormal heart rate or heartbeat, and they might want further investigation. Could be done just as a baseline, perhaps pre-operatively, or the child could present with chest pain potentially. So the first thing to do is you could decide whether to place the limb leads or the chest leads first. We'll talk about the chest leads first of all with Boris. So ideally they want to be placed just on his wrists here. One there and also here. If you can locate them over bony prominences, generally kind of the radial bone, then that's a good place to do because it will produce a better reading on the whole. So some on the wrists and some on the ankle bones there, or the malleolus. Now, children may be slightly more difficult to place them here in that they may be moving their limbs around lots. You can move them further up the body, closer to the torso, but just make the person who's reading the ECG aware because it can affect the readings that you get. But here is ideal if possible. You might want to employ distraction techniques if able. Moving down to the chest, you start by looking at the top of the sternum, so the breastbone in the middle of the chest here. Starting at the top, you want to feel down for what's referred to commonly as the angle of Louis, or the sternal angle. This is the joint where two parts of the sternal bone meet. From there, if you go slightly to the left or right, you will feel a an intercostal space. This is the muscle between two ribs, and that's your second intercostal space in line with the angle of Louis. The first ECG electrode is going to be placed on the right of the fourth intercostal space. We're currently on the second, so we're just going to feel past the rib to the next, which is the third, and then down again to the fourth, about here. And the ECG electrode goes just to the right of the sternum in that intercostal space. So this is what's referred to as C1 or V1 in some circumstances. ECG chest placement 2 goes just to the left of the sternum, so mirroring the placement here. We're then going to skip V3 for the moment and go to V4. Now this is placed on the fifth intercostal space. So from where you are, feel a further rib space downwards and follow this across. Remember the ribs curve to the mid-clavicular line, so the middle of the clavicle bone, and that is V4. V3 is then placed midway between the two. And being quite young, young Boris here Might just need a little bit of lifting that to make sure there's enough room to attach them without overlapping. We're going to skip V5 for the moment for the same reason as V3 and go to V6, which is placed in line with V4 here, and it's mid-axilla. So the axilla is the armpit, so it goes down the middle here on the same plane. And V5, last of all, is placed between V4 and V6. So should look something like this, making sure that we start on the right and work round to the left because the heart sits slightly on this side. Okay, we then would attach the leads of the ECG machine, which will be labelled. There'll be some shorter leads, which say C1 through 6, so C1, 2, 3, 4, 5 and 6, and then the limb leads here. So right, left, and they'll be labelled appropriately. The left foot lead is labelled as F, and it's a green colour. The way I remember where to place it is that the yellow, or left limb lead, is left upper limb lead, sorry, is yellow, so like a sun, and then green. Yellow sun over green grass. And then the last one is coloured black and goes on the right lower limb. You can use your common acronym of red, yellow, green, black, ride your green bike, if that so suits. Okay, working round in a circle.
Okay, so next, I will just revise regarding the ECG interpretation. So as we all know, when it's come to interpretation, there are several items that we need to mention, including rate rhythm, cardiac axis, P wave, PR interval, QRS complex, QT interval, ST segment, and T wave. So for rate, basically how we are going to have the numbers, we count the number of the big square between the R's, and then the normal range of the heart rate according to the age of the child. Okay, so for rhythm, we calculate, we see from the R's and R's intervals, and if there is a presence of P wave, it indicates sinus rhythms. Okay, so next, regarding the cardiac axis, so basically we will refer to the LED 1 and also AVF. So as Dr. Ahmad Kaid taught us, for left one we will our left hand, and AVF our right hand. So if both positive, so so it is in the right place. So if the LED one up positive, but the right but the AVF is negative, so it is left axis deviation. Same goes to the if AVF is positive and LED one is negative, it is right axis deviation. Okay. Next is P wave and PR interval. So for normal P wave, it will be about 2 to 3 little square. So there are several abnormalities that we can see in the P wave, including white P wave, in which it shows left atrial enlargement, taller P wave show right atrial enlargement, prolonged PR shows atrioventricular block, and also short PR associated with WPW syndrome. Okay. Next is QRS complex. Normal, it is not longer than 2 to 3 little square, and abnormalities that we can see including M sign in V1, which indicate right branch block, or V6 indicates left branch block. Okay. Next is QT interval, in which for normal it is less than 0.49 second in 6 months and below, and less than 0.44 in 6 months above for QT interval. So the abnormalities that we can see including Okay, doctor. Prolonged QT, including in QT long syndrome, hypokalemia, hypomagnesemia, and hypocalcemia. Okay, next is ST segment. So we can see it is elevated or depressed, showing that there is infarction or ischemic, and also the T wave. Some abnormalities that we can see is including peak T wave, flattened T wave, and also large and deep T wave. Okay, next. Hassan. Hassan. Okay, so this will be my last slide. So regarding the normal ECG findings in pediatrics. So in pediatrics, we expect that we anticipate to see the increased heart rate more than 100, and also apparent of right ventricular strain, short PR and QRS duration due to smaller cardiac size, Q wave in the inferior and left precordial legs, and also newborns ECG is similar to adults ECG with right ventricular hypertrophy. So basically, there are several abnormalities that we can see in the ECG of pediatrics, in which it is normal for pediatrics but abnormal for the adults. Okay, so I think that's all from me regarding the ECG.
Okay, good. Next. Any questions? ECG is very important.
I have a question. Because this one in this case yang Hafiz present, we insert the 6 lead. Dia kalau macam ada certain case yang saya tengok dia guna 3 lead ECG. Kalau yang tu placementnya macam mana tu?
3 lead is chest lead. 3 lead is limb lead. So basically you just start limb lead lah. Satu dekat, you know, the color coded, the yellow, green and red and black. You call it 3 lead lah, tapi it's actually 4 lead lah sebenarnya. Masuk tangan, letak kat tangan je. Tangan kanan, tangan kiri, and also 3 lah, tangan kanan, tangan kiri, and also dekat kaki.
Kiranya how we decide yang nak guna 3 lead ke, yang 6 lead ke, 12 lead ke?
Okay, for monitoring, for example, if just want to monitor tachycardia lah, for example, you are giving medication to someone and then you are monitoring for tachycardia, just for usual monitoring, usually 3 leads is sufficient. But in resuscitation, if you're resuscitating, or if someone with arrhythmia, known arrhythmia, then you have to do all the 12 leads. The 3 leads is mainly for continuous monitoring. It's not for to do like stat ECG, so you got 3 leads. No, if you want to do ECG, then it has to be 12 leads. But if you want to monitor for heart rate or monitor for any complication, or you are giving medication that possibly cause arrhythmia, then you can just place 3 leads. Because it will produce a single lead, which is lead 2. Lead 2 wave. They can produce only one wave. Okay, faham kan? Tapi whenever you want to do ECG, you have to do 12 leads. Minimum. Sometimes you may need to do the posterior leads as well. Or the right-sided lead. And that's the additional lah. Posterior leads or right-sided leads. Which means you do the usual left-sided ECG, but in mirror image. So you do on the right side. But usually that's more in adult lah. But in pediatric, we do sometimes the posterior ECG rather than the right side. Okay. ECG is very important. If you understand ECG very well, you can actually depict or you can imagine the shape of the heart. And you can actually diagnose a lot of heart disease. You know, the structural heart disease macam VSD, ASD, TOF, Epstein anomaly. You can actually diagnose this by using ECG. Okay, next. Make sure you keep your presentation within 10 to 12 minutes maximum.
Okay, so next is bone marrow aspiration and trifine biopsy. Okay, so these are my table of contents. So bone marrow aspiration is a procedure that removes a sample of the liquid portion of the bone marrow. A bone marrow biopsy removes a small solid piece of bone marrow. So it is usually done at the posterior superior iliac crest. Okay, so the way to find the location is through palpation and also CT guided. Both of it have high accuracy and low complication rates. It can be done inpatient as well as outpatient. Okay, so for the indication, a patient has hematological disorders such as it is a definitive diagnosis for leukemia, multiple myeloma, lymphoma, and also unexplained anemia and others. And it is also done in case of suspected aneuploidy in infants, and if there is fever of unknown origin, and if there is any atypical fungal and parasitic disease, for example, caused by histoplasmosis, leishmaniasis, and cryptococcus or Q fever. So there are several contraindications. For example, if the patient has bony resorption due to metabolic or lytic process, such as in multiple myeloma, so we should avoid the sternum, and we should take from the iliac crest. Okay. So sometimes some believe that thrombocytopenia can be a contraindication. However, if we're afraid of bleeding, then we can actually transfuse the patient with platelet if the patient is clinically warranted for bone marrow aspiration. But we can still perform the procedure even if the platelet count is below 20,000 cells per microliter. For the absolute contraindication, actually there isn't really an absolute contraindication. However, it depends on the patient for patient. So if there is suspect of severe bleeding, for example, in severe hemophilia or in severe DIC, then it is contraindicated. Okay, another contraindication, biopsy at the sternum. So some other contraindication can include like if there is patient is not I mean the patient is very difficult to control and they have any anesthesia or severe energy to anesthesia, then it may be contraindicated. The complication, postoperative bleeding due to since it is a high vascular has high vascularity. Okay, so to avoid this, we can add manual pressure or pressure dressing, retroperitoneal or gluteal hemorrhage. It is very rare due to injury to the internal iliac artery or superior gluteal artery. That's why correct positioning is very important. They can also be cardiac tamponade and death in case of if you're trying to aspirate from the sternum. Okay. All right. So they can also be infection because it is an invasive procedure. It is minimized by proper sterile take. Tumor seeding in case of there is if it is from a metastatic lesion. Damage to local tissue in case of non-cooperative or combative patients. So we can avoid this by giving local anesthesia or by sedation as well as. Okay, so for the equipment, we need the bone marrow kit, which includes sterile drips, needles, syringes, an aspiration needle, a biopsy needle, usually the GEM-CD needle if it is located at the posterior iliac crest. So this is the normal area that bone marrow aspiration is taken from. 1 to 2% lidocaine with or without epinephrine. And specimen slides, specimen containers depend on what type of pathology that we are investigating. So here you can see the sterile wipes, and these are the needles and the syringes and the containers. Okay, and that's for the green one here is for the tryptophan biopsy. Okay. Okay, so the methodology, first we have to identify the landmark. So if we're using the posterior press, so we have to identify. We have to wear proper PPE, can be sterile or non-sterile, to organize our equipment and prepare the anesthesia. So first, we make a small incision, okay, at the skin entry site. Select bone marrow needle, and then scan for a proper angle. Okay, so we have to scan the region of interest to make sure the proper angulation has been achieved. Actually, it is done at 90 degrees. Advance needle into the bone. Advance needle into the bone while maintaining gentle forward pressure. Once we have entered the bone, marrow cavity, remove the stylet. So first we have to enter the cortex. Usually the cortex is the hardest part, but once we have entered the cortex, it'll be easier to go inside. So take the aspiration, attach 2 milliliter syringe to end of the needle and obtain the aspirate. So basically first, we take our syringe and we put in lidocaine or epinephrine. Then we insert into we find the area first, and then we locate the location of the iliac crest, and then we mark it with a straw, and then we insert the lidocaine as well as epinephrine, and then we have to make sure that we sedate the surrounding area as well. Okay, so up, down, left, right, and then after that, we take out a syringe, we make a small incision, and once we make a small incision, we can put in our we can put for the what do you call here? Yeah, this is the technique. Okay, we can put our syringes, and then we can aspirate. Okay, so when we're aspirating, we should twist the handle, count 360 counterclockwise, and aspirate. Because once we do that, then it's easier for us to aspirate the material. So we continue to do this until we have enough. Okay, so here you can see. So insert the needle. So this is a bit more technical. There's a video. I'll show you the video. Hope it doesn't lag.
The procedure starts by finding the correct level for the biopsy. The biopsies are taken from the upper iliac crest with access via the ventral spine. The midline of the spinous process is identified and the iliac crest is located by palpation. When the correct point is found, the puncture point is marked using a straw. This is to avoid losing the marking after washing. The area around the puncture point is washed with colored chlorhexidine. The procedure is carried out aseptically, but without sterile drapes. The area around the puncture point must remain sterile during the whole procedure. Correct placement of local anesthesia is important for how the patient experiences the procedure. 10 milliliters of xylocaine with 10 milligrams per milliliter of adrenaline is normally used. When the needle reaches the periosteum, the anesthesia is given time to work before the numbed area is expanded by angling the needle in 4 directions. Disposable and reusable aspiration needles are available. A reusable needle is used in this video. The needle is pushed toward the posterior iliac spine and rotated with careful pressure until it goes through the cortex. When the needle is in the spongy tissue, the trocar is removed and a 5 milliliter syringe is connected to the needle. 0.2 to 2 milliliters is quickly aspirated for a regular bone marrow smear. 3 small and 7 larger smears are placed on slides. The slides are tilted, and the blood, which collects in the lower edge of the smear, is removed before it coagulates. We then use another slide to make a few regular smears and some which are squeezed. The smears are dried with a fan before fixation and staining. A new aspiration needle is used for aspiration for flow cytometry. 0.5 milliliters of monoporin is placed in the syringe in advance to stop the aspiration.
Hello, I think the video is lagging. I've already give you guys, I'll share with you guys the link after this. The video is very succinct and it's appropriate, so you can actually follow, and it's very, I mean, it's for educational purpose, so I mean, it's very good for you guys to see it. So I've already shared, I will share the link in the WhatsApp group and you guys can watch it later. Okay, that's all from me.
Okay. Any questions? Sepatutnya dalam video you can pakai sterile gloves. Yes, it is a sterile procedure. And usually when we do BMA, when you do BMA kan, usually you will need multiple puncture. It's not only a single puncture to get adequate sample or a quality sample. Usually we will puncture at the same hole, at the same incision, but then we move the needle inside rather than puncture multiple hole. Faham tak? So there's only one incision opening, and then you move around your needle in under the skin and to puncture the bone, the axis.
The biopsies are taken from the upper iliac crest with access via the ventral spine.
Okay, I think this is better.
Losing the marking after washing. The procedure is carried out aseptically, but without sterile drapes. The area around the puncture point must remain sterile during the whole procedure. Correct placement of local anesthesia is important for how the patient experiences the procedure. 10 milliliters of xylocaine with 10 milligrams per milliliter of adrenaline is normally used. When the needle reaches the periosteum, the anesthesia is given time to work before the numbed area is expanded by angling the needle in 4 directions. To avoid unnecessary trauma to the skin from the aspiration needle, a small
Okay, I think you just skip lah. Just watch this video on your own. Next lah, move to next presentation.
Okay, bro.
Okay, so I'll be presenting about CPR in children. My name is Mashita. So next for introduction. So CPR, cardiopulmonary resuscitation, is defined as life-saving procedure that involves rescue breathing and chest compression. So for children, it is defined as 1 year of age to the start of puberty. Okay, next. So what indication of CPR is first cardiac arrest or pulseless, and second if the patient is bradycardia, specifically if the heart rate is less than 60 per minute with poor perfusion. Next. So these are the equipment needed for CPR. First, PPE, gloves, apron, and mask. But if it's available, next is a back mask device, and also we need automated external defibrillator. Next. So the method, we have the mnemonic, doctors ABC. So first danger. So make sure it is safe for us and also for the patient to help. At this time, we need to wear PPE, glove, apron, and look out for blood spill, sharp, and try to make the environment is safe. Next is our responsiveness. So we need to check for the child to respond. Just ask, are you alright? Okay, and then ask, shout, shout for help. So we need to ask anyone there for help and bring a defibrillator. And then airway. So we need to open the airway, make sure the airway is not obstructed, and perform the healthy chin lift. And then next, B is breathing. So first we need to assess for normal breathing. Just look for normal breathing in less than 10 seconds. And if there is no breathing or abnormal breathing, we need to give 5 rescue breaths. Okay, then C, circulation. At this time, we need to start chest compression. So before we start, we need to look for a sign of life and check for the pulse. So if the pulse is less than 60 beats per minute, or there's a pulse, cardiac arrest, pulseless, we need to start the chest compression. So chest compression need to be done in a ratio of 15 compression and 15 compression to ventilation, and each ventilation is in 1 second. Okay. After securing the circulation, then proceed with the defibrillation. So we need to assess the patient if need to for shock. So we need to attach the defibrillator. The pad need to just attach to the front chest and also the back. And then I do not attempt chest compression when we give shock to the patient, and just follow the AED voice prompt. And then okay. Next is for the method for rescue breath. So how we need to perform the rescue breath? First, we need to open the airway by doing the healthy chin lift, and then pinch the child nose. Place your mouth over the child mouth, making it a tight seal. So blow a breath into the child mouth over 1 second. And at the same time, just look for the chest rise when giving the rescue breath. And then we need to give 5 rescue breaths. Next. Okay, for the chest compression, first we need to locate the xephisternum, finding the angle where the lowest rib and joint in the middle, and then compress the sternum, 1 finger breath above the xephisternum. Okay, so we need to place the heel of one hand, okay, only the heel, and lift the finger to ensure that the pressure is not applied over the child rib. Only the heel of the hand is applied. Avoid compressing the upper abdomen area, and make sure to position ourselves vertically above the victim's chest. Okay, with your arm straight and compress the sternum. So compression should be sufficient, just at least 1/3 of the depth of the chest, approximately 5 centimeter. And then release the pressure completely and repeat at rate of 100 to 1,200 per minute. We need to make sure that the chest is returned to its resting position before starting the next compression. So after 15 compression, we need to give rescue ventilation. And then, so we need to continue compression and breathe in a ratio of 15:2. So this next is the video to make sure this is more clear.
Okay, so this is child CPR. We're gonna check for danger like before. It's most important that you don't go rushing in and get yourself hurt. And it must be safe for you, the casualty's family, bystanders, and emergency services who you're gonna call to help you. So this is a child, he's under 8, but over 1. We're gonna check for breathing like before. Tip his head back, hold the bony part of his chin, balance yourself on your elbow, look, listen and feel for 10 seconds. See his chest rising, see his belly rising, feeling breathing on your cheek, hearing breathing in your ear. So we've not got that in this case, so we're going to do 5 rescue breaths first. The likelihood is it's airway and lungs, not heart related, so we're going to reoxygenate his blood. So we're going to tip his head back, pinch his nose, cover his mouth with mine, looking down the length of his chest. I'm going to give him 5 breaths. As soon as I see the movement in his chest, I'm going to stop blowing. Otherwise, I can overinflate his lungs. So now to do compressions on the or use the and then carry on until qualified help arrives.
Okay, so later I share the video because of the lagging. So these are the complications that might arise in doing the CPR. First, rib fracture, pneumothorax, pneumoperitoneum, and also hemorrhage. So I think that's all for my presentation.
Okay, continue.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will continue with the presentation CPR in infant. Okay, next. So basically, some of it will be like repetition from the previous what have been presented by Mashita just now. So basically, CPR as it is an emergency life-saving procedure consisting of chest compression and ventilation in infant which is less than 1 year old. So among the indication, first is cardiorespiratory arrest. However, it is important to note that usually in infant, it is not because of the cardiac problem, but it is secondary to respiratory problem. And next is bradycardia with less than 60 beats per minute before perfusion. And also, I would like to add also other indication can be in patient who is unconscious, in infant who is unconscious and choking infant. Next.
So as for the complications, so there are several complications. First is like bruises and ribs and sternum fracture, pneumothorax, aspiration, pericardial tamponade, and also aortic laceration. Next. So the equipments are usually we use a back valve mask and also AED if indicated. So next. So basically, these are the overview of the steps that I'm going to describe after this. Next. So the first one is danger. So basically, we have to ensure the safety of the surrounding, the healthcare workers, and also the infant. And then second one, we need to check the responsiveness of the infant by gently stimulate the infant. And the third is we need to shout or call for help. Next. Okay, the fourth, we need to open the airway. So there are two ways of opening the airway, but the first preferred method is the head tilt and chin lift, in which we will place our hand on the forehead and tilt the head back. We lift the chin by placing the fingertips on the chin. And if it's then the other method, we can use the jaw thrust, in which we will place our fingers, two fingers of each hand behind each side of the mandible, and we will push the jaw forward. Next. So the fifth one is breathing. So basically, we have to assess the breathing by looking, listen, and feel. First, we look for any chest movement, and then we listen for the breath sound and feel the breath by putting our cheek at the nose or the mouth. So if let's say if it is a normal breathing, then we will proceed, we turn the infant into the recovery position. However, if there is abnormal or no breathing, so we have to ensure the natural position of the head, and then we will perform the rescue breath by covering. If we use our own mouth, then we have to cover the mouth and the aperture with a good seal. And also, if there is a back valve mask, then we can use it. Initially, we give 5 rescue breaths. And the sixth is circulation, in which we will need to check for the sign of life. First, we can either feel the brachial pulse or the femoral pulse. Usually, we will feel for the brachial pulse, and this step should not be more than 10 seconds. And let's say that if there's no signs of life, then we have to immediately start compression, chest compression. So we will depress the sternum by at least 1/3 of the depth of the chest, or 4 centimeters. And then we will repeat the chest compression at the rate of 100 to 120 per minute. So when performing the chest compression, we need for every chest compression, we need to allow the chest to return to its resting position. And we will do this in a ratio of 15 compression to breath. So compression 15 and to breath. So next. So basically, there are two techniques when we want to perform CPR in infants. There are two finger techniques and circular technique. So we use two finger techniques when there is only one healthcare worker. So basically, we will use we will use the two fingers and compress the sternum. One finger breath over, which means we need to the landmark is it is just below the intermammary line or just below the nipple on the sternum. Then we will compress at a depth of 4 centimeters. For encephalic technique, in which there will be more than 2 healthcare workers, two or more healthcare workers, we will place both our thumb flat side by side on the lower half of the sternum with our tips pointing toward the hip. Then we will spread the other finger to encircle the lower part of the ribcage with the tip of the finger supporting the back. So as you can see from the picture. So next, I brought. So there are two videos concerning about the technique. So let's watch the one hand technique first.
If you arrive on the scene, check the scene for safety. Check the infant for consciousness. Gently tap the shoulder or flick the bottom of the heel and shout.
Baby, baby, are you okay? Are you okay?
No response, call 911 immediately.
Call 911.
If the infant is lying on their stomach, turn them onto their back. They should be lying on a hard, flat surface. Check for breathing and signs of life. Watch their chest for any normal movement. Look for signs of life and breathing for no more than 10 seconds. No breathing or signs of life, begin CPR. Position 2 or 3 fingers on the center of the infant's breastbone just below the nipple line. Compress the chest 1.5 inches in depth 30 times.
1 and 2 and 3 and 4 and 5 and 6 and 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
After giving compressions, give breaths. Tilt the infant's head back slightly, using one hand on the forehead and lifting up on the infant's chin with 2 fingers with the other hand. Cover both the infant's nose and mouth with your mouth. Give 2 small, slow breaths, watching for the infant's chest to rise. Continue with 30 compressions, 2 breaths. Continue CPR until you see signs of life, another rescuer takes over, or help arrives.
Then play the other video. The answer content.
Baby, are you all right? Are you okay? There's no response from the baby, so I call for help. You in the plaid shirt, go call 911 and come back. If you find an AED, bring it with you. Or I'm going to access 911 or call a code. Now I'm going to check for normal breathing and check for a brachial pulse. No more than 10 seconds. There's no pulse and no normal breathing. I'm going to go right into compressions. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 12, 13, 14, 15. Breathe. Breathe. Good breaths. They both went in. 3 and 4 and 5 and 6 and 7 and 8 and 9, 11 and 12 and 13 and 14 and 15. Breathe. Breathe. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15. Breathe. Breathe. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12 and 13, 14, 15. Breathe. I got to switch after this one. Breathe. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 13. Breathe.
Yes, and you can pause the video. So that's for the one hand technique and also encyclic technique. So next. So okay, next is the recovery position. So any unconscious infant with clear airway and is breathing normally, then we will turn onto the side into the recovery position. So basically the principle we want to place the infant as near as a true lateral position, in which we want, because we want to enable the drainage of fluid from the mouth. So there are a few ways to keep the patient position, the infant position stable. So for example, like placing a small pillow behind the infant bed, and also we need to ensure that there is no pressure on the chest that might impair the breathing. And also we need to place in a position that allow the infant to turn onto his side and to return him back easily and safely. And then we have to ensure that the position is accessible, that the position that is placed is where the airway is accessible and easily observed. Okay, next. So basically, this is just the algorithm I took from American Heart Association Journal. So basically it is the same. So you can read it later. And I think that's all for our presentation today. Doctor, do you have any comment?
So only four. Only four. Hello?
Yes, only for.
Ke ada another session?
No, this is the last.
Okay. So tadi CPR, BMA. Number one is apa tadi? Lupa dah.
ECG.
ECG, BMA, and then 2 CPR.
Yes.
Yang tu je?
Yes.
Ke group lain akan present lain?
Yang tu first session. Dah buat minggu lepas.
Oh ya, dengan siapa?
Dr. Chan.
Oh, okay. Okay, Samba nanti can you list down all the procedure yang you guys buat? And bagi kat I.
Okay, sir.
Boleh tak? You guys year 5 kan?
Year 5.
Kan?
Yeah. Betul.
Okay. So nanti list down all the procedure. Remember procedure is very important tau, sebab usually unmanned OSCE memang tu akan ambil daripada your list of procedure. In fact, you punya exam end of block kita dah siap dah. So betul lah. So you have to ni lah, one of the procedure, 1 or 2 of the procedure akan masuk unmanned OSCE. Anyway, so okay lah, ada questions tak? Last question. Nanti I WhatsApp siapa ni? Siapa lah nanti I WhatsApp. Hafiz what? I WhatsApp Hafiz dia ni, the marks. Okay. Okay, that's all. Thank you. Kita tanggung atas speaker Farah. Thanks for us.
Thank you, Doctor.
Thank you, Doctor.
Okay, thank you. So,